All right. Thank you so much for joining in today. Apologies for the few minutes we have lost. These are CME series organized by the Uganda Association of Psychiatrists, and we always have one CME every month, a month. So today we are glad to be discussing a very important and interesting topic about mental health among men. And today's session, as you all looked at the flyer, is going to be spearheaded by our own president of Uganda Association of Psychiatrists, a senior lecturer at Makerere University. That's Dr. Mwesiga, Emmanuel Mwesiga. Apologies, we have received apologies from Dr. Kalani, who was supposed to moderate, but he got another conflicting engagement at this time. So receive his apologies. And we are going to start straight away. Yes, thank you so much. I think Dr. Mwesiga is able to share his screen. We are going to share the CPD link towards the end of the session in the chat. So you'll be looking out for the link. And maybe to just give you a brief feel of the session, we received expectations from the team, from the registrants, and people were interested to know the brain changes and affective disorders in men, common stressors fueling depression and how men cope, how mental disorders affect men socially, psychological problems in teenage boys, neglected psychiatric conditions in Ugandan men, and very other interesting expectations. So I wish you a very interesting session. And as I said, we are going to have Q&A session towards the end of the session. So I welcome Dr. Mwesiga.
Thank you, Dr. Mwangs. Thank you for stepping in. So I think as I've been introduced, I'm a senior lecturer at Makerere University and the president of the association. And because of this Men's Mental Health Month, we decided to have 1 hour CME on the topic. I think it's important to note that this talk is slightly biological, not biological leaning. But on Tuesday at 7 p.m. we have another talk that talks about more risk factors for men's mental health besides the biology. So the talk really today is about how the biology works, primarily how the biology works, and then how it links to psychosocial aspects to bring about affective disorders. And by affective disorders, we mean depression, primarily depression and anxiety. I thank Dr. Nabwire, who insisted that I present this talk. And I think I enjoyed preparing for this talk because I read a lot that maybe I didn't know before. Dr. Abatio the other day was asking about why men's health is important, and I think this will clarify it. Hopefully, this will clarify it. So I think I'm starting from home, and these are actual figures from the 2024 census. A caveat is that the 2024 census asked not full diagnostic criteria for the disorders. And in there, they are reported as probable. So it's probable bipolar, probable depression, etc. But one thing you see is that in all the disorders, maybe apart from suicidality, and we'll come to that, there is men are often less diagnosed, and but we also know that men have higher suicide mortality, alcohol harm, like complications. But they seem to be less diagnosed. So we need to understand how this lower diagnosis coexists with. So why is it that we're not diagnosing, but when the men come in, there are severe complications like suicide, and really that's generally what the talk sort of like wants to frame it about. Um, so I think I'm going to start from the end, and I'm going to make the key phrases for today. And it's to say that sex modifies affective disorders, and then so it changes its presentation, right? But then the diagnostic instruments we use, the culture we are in, um, they sort of like alter what we see. And then that means that we need to sort of like have a new viewpoint in managing depression and affective disorders in men. So basically, being male modifies the biology of the affective disorders at many time points, and then it gives the affective disorders certain distinct characteristics in males. But then it's driven, although it's distinct, the statistics are driven by how we measure it, what masculinity permits men to say, um, when they reach crisis and how they reach crisis. And because of that, then we need to like rethink how we manage affective disorders like depression in men. So we'll start with the first part. And the first part is that sex differences modify affective disorders. You cannot have this conversation without understanding what men male sex versus male gender means, or men's sex and sorry, there's a chat. Okay, it's not for me. Okay, so Dr. Mwangzi, you tell me if there's anything in the chat. I want to check on it again. So you can't have
Sure,
this conversation without understanding what sex and gender are. I think many people confuse them. They see the male sex and they think it equates to male gender. And sex, on one hand, is biological, XX, XY, right? And um, and uh, and gender is more the experience. So it's the expectations around this expected strength, emotional control, how you perform, sexual function, and status, which shapes how you feel about certain things, how you experience distress, whether it is named, whether it's sought. So sex and gender, so many people confuse male sex and male gender. Just because they see the male sex, they assume that everything is the same for the male gender. And it's important to know that they are very distinct, but not independent. So I'll give you an example. In men, a social event like unemployment, okay, let me say in people, in human beings, a social event like unemployment is not neutral. Biologically, sex-wise, sex differences, it will alter sleep, substance use, okay, immune function when you're unemployed, in very many pathways. But at the same time, it will alter how you feel about yourself, how you talk about yourself, and things like that. So it's very important to distinguish between the sex when you're talking about males. There's sex and gender. Gender is more like societal expectations, and the sex is what the biology gives. And all of these things work together to drive disease disease perception, help seeking, use of healthcare, and all these things, and also the pathology and how they present. And I think that's important for today. Then the next issue is that these sex differences are not all the same. So there are sex differences which we refer to as type 1. The end point may be present in one sex but absent in the other. So like copulatory behavior in birds, how we nurture, courtship and courtship displays, that's sexual dysmorphism. Then there are sex differences, right? These are on a continuum between males and females. And this is very important because like when you talk about the biology, we are talking about the sex differences. It's not that women, the hormones sort of like differ greatly in males and females. No, it's just on a continuum where some is more but everyone has the same. And this impacts how we deal with different things, pain, food. When you're in medical school, you learn about ovulation and how female sex will wear colorful dresses and be happy and things like that. And then when it's premenstrual, it's different. Same thing with men, okay? When testosterone is high, they feel powerful, etc., etc. But that hormone, the hormones are almost balanced within all the sexes. And then the third sex difference is sex convergence and divergence. How we deal with stress. And really this is not nature, it's more nurture. And I think that's important. Now, then we have to talk about depression or affective disorders. And I think the key thing here is that there are so many mechanisms that drive depression. This neuratorium slide is important because it shows you that there are so many things that drive depression at a biological level. Neurotransmitter systems, brain structure, neuroplasticity, epigenetics, the HPA axis, immune, microbiome, etc., etc. And this tells you that the neurobiology of affective disorders or depression per se is quite complex, and there are many combinations. And maybe that's why it's such a complex disease, because it's not one thing. It's not malaria parasite causing anemia and things like that. Okay? And male and female depression are sex modifications of these systems. So what that means is that there are slight differences between the immune system, the neurotransmitters, the HPA axis, okay? Between male and female. But because there are sex differences, it is on a continuum. And sex modifies these systems in either direction. And so for setting the scene, I think that's very important, is that what we are talking about now are sex differences. Those are the type 2 differences that the biology occurs in both males and females, but we're now trying to see what is more weighted towards the male side. And why that is important is that it's important to say that even if the presentation may differ between the sexes, they are not different diseases. What we have is just modified mechanisms and modified experiences. Okay? So the sex does not create a separate disease, but modifies the same, the affective mechanisms through different parameters, hormones, chromosomes, environment, and stuff like that. And these the systems are shared. So the sex hormones are the same, chromosomes almost the same, slightly different, apart from one. The brain is almost the same, but it's just these underlying mechanisms, how they alter these things that leads to these changes. And then also another critical point is that the critical point that we'll look at is also the developmental stage. Okay? So like there are critical windows for development in prenatally that drive more male-related mechanisms that you will then have risk for depression. And yet at maybe at postpartum or intrapartum, there are mechanisms that will drive similar mechanisms. Today we won't look at lady, it's the men's month. We won't look at the female sex, but maybe around pregnancy, there are mechanisms that drive such that you see a lot of affective disorders like depression around that time. Now, these are the these are the 7 key things that we're going to look at. That how sex and gender experience differences across genetics, development, neurotransmission, HPA axis, neural circuits, immunity, and clinical expression. So the sex differences can occur at multiple levels, and it's not just about testosterone. And so the reason why we put the idea of testosterone is that there's this idea that everything is just down to the one difference that men have, or what people think the one difference men have, which is testosterone. So it's supposed to explain everything around the male sex. But what we are saying is that there are differences along various mechanisms that make affective disorders like depression to be expressed differently in the male sex. Okay? So don't worry too much about these slides. I'm just listing them because I can't go through everything, but I'm just showing you how they come. So genetics, XY complement, Y-linked factors, etc. in genetics can all lead to different thresholds for vulnerability or resilience in males and females. Okay? There are certain neurodevelopmental traits that are more in males than females. That's all genetic. Okay? And the reverse is true for others. Impulsivity, stress reactivity, treatment response could all be driven by genetics. So sorry, that column is supposed to be talking about the expression. There's a potential male modifier, and then what you will see, what will be expressed. So development again is also a mechanism because prenatal, pubertal androgen exposure leads to differences in stress sensitivity, threat processing, reward seeking, emotional inhibition, etc., irritability, withdrawal. You can go on for all the mechanisms. Neurotransmission, the effects of androgens, estrogens, neurosteroids will determine motivation and hedonia, which are key drivers in affective disorders, reduced drive, reduced sexual drive, anxiety, and things like that. Remember, it's 6 differences, so it's on a continuum. But now we are talking about the ones that sort of like drive more, that have a more male preponderance to drive these changes. HPA axis, especially HPA and HPG, hypothalamic pituitary gonadal crosstalk. So between the two, then you have hyperarousal, insomnia, anger. You then have, because of the way the 2 mechanisms are talking, then you have that. And we could go on for neural circuits, immunity, metabolism, and clinical expression. But let me go now to specifics such that we see what I'm talking about, such that I move faster. So here we're talking about genetic liability and gene regulation. So many people know the difference between X and Y chromosome, but fewer people know that there's an SRY gene that is expressed just before delivery, and it sort of like pushes this epigenetic programming of male cells. First of all, there's a testosterone surge there's development of the testes, and then a testosterone surge. And this testosterone then changes the way things happen later in life. And these things are things like resilience, traits, impulsivity. It doesn't start all when you're a teenager. No, because of your genes and this SRY chromosome, just before delivery, you push out, there's this surge of testosterone, and that is going to prime you, synaptic pruning and all the rest, that prime you later for how you'll be resilient, how you respond to treatment, and things like that. So that's an example of a genetic mechanism. We can continue with XY complement. So XY complement basically says the chromosomes that determine male biological sex, right? And one thing that's very interesting is that testosterone ideally is supposed to lower anxiety. But this male sex chromosome complement raises anxiety and mood and anxiety-like disorders. So while the complement is increasing anxiety-like behavior, this effect is opposed by testosterone, which has an anti-anxiety effect. So you see how these genetic differences, these genetic sex differences are driving how you will present with different symptoms. So if you have this overexertion of this XY complement, then and less testosterone, then you are more anxious. Okay, and that's just an example at the genetic level. We can look at it at developmentally. I've already talked about how just before delivery males produce excess testosterone, and then it determines how they'll be resilient, etc., etc., right? But then there's also the issue of puberty as a second organizational window, right? That there is a second surge of, so there's the first one of prenatal androgen exposure, okay? But then there's a second pubertal organizational window, okay? That will then further drive the way you relate to stress, the way you process threats, the way you seek rewards, okay? Emotional inhibition, irritability, withdrawal. So these are the sex differences that are important. Again, going back, it is more in males, but it's on a continent. We can continue. We can talk about neurotransmitters. Now, this slide was not very clear, and this one is really more about females. But if you look at this, these are the different pathways that are important for affective disorders: glutamagic, GABA, serotonergic, and dopaminergic, right? And then you look at where the different estrogen receptors are, right? And they're just passing throughout. So it's just showing that hormonal receptors, how many they are. Again, now I'm looking at the sex differences from a female side. They're interacting with circuits and pathways to drive symptom expression. We have already talked about this in the reproductive years. So you will always argue that, oh, why is depression more in reproductive years for females? It's being driven by certain mechanisms around neurotransmission and neurosteroids, where estrogen, is more in these years, and it's driving low motivation and hedonia and all these other things. Okay? But it shows you that there are many issues happening. There's a neurotransmitter, there's development, there are hormones and things like that. And it's a key thing. We can talk about stress response. Many people talk about HPA axis, okay? But then there's also the HPG, the gonadal axis. So now testosterone surges during two critical. We've talked about perinatal and we've talked about puberty, okay? And one of the key things it does during those two surges is to alter how you respond to stress later in life, in adulthood. Okay? So testosterone, of course, a lot of it is converted to estradiol, it becomes like a blueprint for future HPA activity. So the gonads are sort of like driving how well your hypothalamus pituitary axis will respond to stress in future. Okay? And at puberty, remember it has started in the perinatal, then at puberty, it works on it to complete this masculinization, okay, of the HPA axis. And what happens then is that compared to females, adult males have less HPA response. Okay. Decreased activation of a specific nuclei in the brain, lower ACTH and corticosteroid, right? And then you have enhanced feedback to other regions, okay? Like the pituitary and activation of limbic system. So all that doesn't matter. What happens in the end is that you start seeing sex differences in how males and females respond to stress. Hyperarousal, insomnia, anger, irritability, somatic stress complaints, fatigue, those are more in male pattern presentations. And this is being driven by these sex differences. Reward, okay? How is it that all of a sudden you have this second surge at puberty, you're getting more reward in certain crazy things, and then you're having behavioral dysregulation. Okay? Again, this is just, I sound like a broken record, but the sex differences are affecting so many mechanisms: genetics, immunity, hormones, the way you relate to stress, the way you experience reward and motivation, circuitry, okay? And now these are making the presentation appear different. So male depression may appear with risk-taking, overwork. So they see somebody, he's gambling, he's sleeping around. They say, oh, he's having a good time. But actually, it's just an expression of depression. Substance use, male gets low, substance use increases, it gets worse. He's more irritable, he's more agitated. It's just the way they process reward. Okay? And it also affects how they seek help and anhedonia and sadness, and how they relate to how they describe sadness. We can talk about the immune function. This is a quick one that just shows you a correlation between PHQ scores and different interleukins. And for males, you see there's a correlation with higher PHQ scores for interleukin 12, and for females, it's interleukin 1 and TNF alpha. Okay, just showing you. And then when you go, then you realize that, oh, this is what leads to greater fatigue, lower libido, you're putting on visceral fat, poor concentration, and then you would present with those things more than the other sex. Somatic presentation, if you read more about interleukins and how they are involved in pain processing, then you find that, oh, men will say, oh, I have more pain and things like that. Okay? Okay. And then also, interestingly, even how they will respond to treatment. This one I just put it there because there's some sort of correlation between the sex differences in immune systems and how the sexes respond to treatment. With males with males with higher white cell counts responding slower than females. But again, it's just showing you that yes, however much the disease is the same, there is subtle differences. I don't want to say subtle because there are these differences that make the experience of the depression or the affective disorders differ in males than females. So we then go to the next part of the conceptualization, which is it that the methods that we are using to count the depression, or is it that the social factors are the ones that are what? Are leading to those differences we saw in the beginning? And what we want to agree is that the biology are the sex differences. Okay? But then we also acknowledge, and this is really the thesis where I started from in the beginning, that biology is the catalyst. There are these small differences. Then on top of that, you add structural differences, diagnostic instruments, masculine norms and culture, who has more access to lithomenes. And now this is the one that is driving the statistics. So you will have lower diagnosed depression because the instruments are more normed on female typical pictures. So they are looking for more sadness, loss of interest. But in a male typical picture, the male you will have more irritability, more aggression, more substance use and things like that, more harm. Okay. They are looking for masculine norms, but you're in a society where there's a lot of stigma, men won't speak and things like that. And then you're also in a society where the men are the ones who have access to lethal, they are the ones who can buy a gun, they are the ones who can, um, jump off a bridge and things like that. So it is then this that drives the statistics. So the thesis is that, look, there are these sex differences that are driving the presentation of the illness, but then there are also these other non-biological differences that are driving the presentation, the measurement, the outcomes, that then starts giving us these differences and makes it look like, well, males don't have what? They don't have that big of a problem. And I think that's important. So, do diagnostic tests miss the male phenotype? I actually, maybe this is why I'm happy. I didn't know this until I read it today. So, again, we have to be very careful about interpreting this data. Because the male scales don't have that good psychometric properties. They overlap with other disorders. There's poor prediction with some subscales like substance use, and we agree that they reinforce a traditional gender bias, which may not be the case because some men now look after kids, do homework and things like that. But you cannot look past the fact that when some sensitivity measures are applied, this sort of like difference between males and females disappears. Actually, there was a paper where I didn't put it, where they were calling it male depression, right? When you start looking at male type scale, when you start using male type scales, ones that are saying, okay, let's look for sadness, let's look for irritability, let's not look for, I don't know, poor sleep, we look for substance use, you then tilt all of a sudden, and there's a lot of more affective disorders in males. Again, with caution, because the psychometric properties, it may be issues with overlap between maybe substance use and depression. But that statistical significance in difference just disappears. And then you say, okay, are we asking the right things? Okay. You then go and say, okay, what about clinical expression? Okay. Are these norms around strength, self-control, self-reliance, emotional restraint, stigma, disclosure, are they the ones leading to less reported sadness, more irritability, more substance use? Okay? Beyond just the biological mechanisms, or is it some sort of melting pot that is leading to this whole thing to come together? And finally, then you look at the outcomes. We know very well that male sex will have, or men will have more completed suicides. They'll use more lethal means and things like that. So is it beyond the biology? What are these things that are making men to have worse outcomes? And so you then have this thesis where you say the actual sex differences that are working at a biological level, genetics, immunology, circuits, metabolism, microbiome. But then there is a second level where there is, the tools we are using, where we are meeting the men, at what point we are meeting the men, and things like that. That then, and that then tells you that there may then be a bigger picture or a bigger burden or a bigger issue around male affective disorders, especially depression. Okay? So basically, the biology is a catalyst. Then you are undercounting. We're not allowed to speak about, men are not allowed to speak about it, or it goes untreated, and then they are coming in late and or they are dying more and no one ever reports. And then so to synthesize, you say that that sex modified biology is a catalyst. Okay. Then there are like three non-biological valves that are making the statistics, that may be making, I don't want to say that may be making the statistics to be a bit different. Because remember, we started from the census says that, well, we're making a big deal about this. There's less difference in males, but our argument is that it is they're actually biological differences that make males to have a distinct kind of affective disorder. And then on top of that, there are non-biological means, instrument norms, and outcomes. Maybe let me not use the word means that drive the statistics lower. And so in there you say that okay, you may never be able to fix the biology. Because that is, as we say, those are sex differences. They're on a continuum. It will be very hard for you to get very specific differences, although they are there. But within those sex differences, there are specific things we can pick on, especially now with artificial intelligence and machine learning. There are specific, we just need a lot of men to be giving us signals. And then there are things that we can pick on and say this, okay, this is a male type of depression. And then now we deal with these other non-biological issues to drive this burden down, and especially to ensure that people come with so that the males have what? Improved outcomes. And this goes to the last point, that then should we have a new viewpoint for managing men's depression? Okay? And the final thesis is that we're not going to ask biological or social. We have seen that each is pulling from one side. But maybe we should ask how these biological, social, psychosocial are interacting in men to ensure that we understand how to drive the needle and reduce poor outcomes. And here we talk of four things: detection, engagement, protection, and treatment. So in detecting, we need to assess better. Again, because of the sex differences, maybe when we are talking to males, we should ask for a bit more things: anger, irritability, sexual function, both at extreme ends of the scale. So just because someone is going around spreading his seed does not mean he's happy. Okay? And that's very important. Screening tools. We've looked about the tools, the setting. Can we find men where they are? Maybe we screen in a prostate, in a urologist's office or something like that. Or emergency departments or substance use services. Okay? Now that's the detection. Then the engagement. How do you engage them? Okay? Because remember, there is the norms and these barriers to disclosure. Okay? We're expected, or men are expected, let me not say we, men are expected to, be strong, not cry. So how do we destigmatize distress, improve health seeking, be explicit about confidentiality? Okay? How do we ask about behaviors and not just feelings? Again, because of these sex differences, the PHQ-9 is not going to tell you so much about drinking, risk-taking. You have lost your job, you're solo, you need someone to talk to, you're like, no, I can't. How do my friends see me? You go to the bank, you get another loan. Men will know what I'm talking about, right? Or you've lost your job, you say, I need a drink to think through it, and it becomes a problem. How do we meet them where they are? That's straightforward. And how do we help with the next step? Well, after we have found out It's very interesting in the clinic. You'll find females or ladies being escorted, or she's sad. Rarely find men being escorted, right? And yet maybe they may have opened up to a friend, but the friend will say, no, you go to the hospital. Females will escort their friend and they will talk and they'll say how she has changed. Men, they'll say, you go, you will tell us when you come back. And when you come back, they buy you a beer. Okay? And maybe we need to figure out how to engage differently. How do we protect? And this is the strongest level on mortality. We need to, one, recognize high-risk moments. A man, however much he looks okay, when relationships break down, all this idea that there are many women, I'll get another one, is not as straightforward as it seems. Unemployment, financial, legal stress, we need to recognize these things. Remember that they are now the biology is working. Your immune system, your microbiome, your neurocircuits, your hormones, within this context of illness. We don't know how to be sick. Okay? Intoxication, isolation. I see many men who like being alone, but maybe that's not the best. Humiliation, defeat, entrapment, and things like that. So that's how you identify the risk, but then you have to act on it. Ask about lethality, safety plan, reduce high risk window. So let's get jobs, etc. Track behavior, active follow-up and rapid recontact and treatment. And then you treat. And then the core treatment, of course, is pharmacotherapy and psychotherapy and a biopsychosocial model. But maybe you must match it to the severity and to the man's goals and engagement. This would go across, right? But the man may be dodging engagement because, he's pretending to be very busy, but he's actually very low. And men, I think as I speak to men, you can reflect on friends you have. It's, I'm so busy, but things are not working out, okay? We treat, we change our lifestyle, we change the social drivers, and we know that it's beyond this whole idea of testosterone. This, okay, yes, if testosterone is low, you go to an endocrinologist and they treat it. But it's beyond that, and I hope over the last 40 minutes I've done that. So I think in summary, this is let me just summarize by saying we have biology, we have biological differences. Then those differences go ahead and are expounded by the way those differences create changes in how males present. Then there's another burden of how we assess for affective disorders like depression in males using the tests we have. We have a burden of of the access to lethal means, okay? And things like that. Maybe I should just show this last slide because it's and then the norms, the cultural norms, okay? And then that's the problem. And to manage that, we then must come back to this idea: detect better, engage better, protect better, and treat beyond testosterone. Thank you. Welcome. Comments or questions?
Thank you so much, Dr. Mwesiga. It's been very, very comprehensive. And I think we have appreciated the neurobiology, and it's not only the biology, but also how we screen, how the culture influences the biology. I think it's been very, very, very helpful. Thank you so much for joining in, the participants. Kindly share your questions in the chat. I think we have had a few questions already. And okay, so one question from Dr. Kamia is asking, how do the affective disorders relate to the neurodevelopmental model of psychosis? And I think more questions are coming in. But I think, yeah, You can also raise your hand. We have about 15 minutes. We can utilize them profitably. I'm seeing a hand from Nelson. Nelson, you'll wait a bit as I I think I'll ask Dr. Mwesiga. Let me list. Should I read them and you respond at once before we have the hands?
Okay.
Okay,
It's
perfect.
okay. Yeah, the moderator, so you can advise. So,
Yeah. Okay, so the first question I've shared it from Dr. Kamia. We shall look for a way of sharing the slides, Mercy. Then Dr. Mose here is asking, of course, he's appreciating the session and the UAP for organizing the session. And this question is, despite advances in understanding the neurobiology of affective disorders in men, which I think has been well elaborated, what are the key neurobiological factors that may explain this gap? And how can this knowledge be translated into earlier identification, targeted interventions, and improved clinical outcomes for men? I think most of these answers have been already shared by Dr. Mwesiga presented. I think when you shared that when you see men having a good time, John was asking, so should we suspect depression in men who are having a good time? I think you'll
I
throw
think
more
that I
light
think
there.
that's Joan, Dr. Abatio is very
Eh,
interesting. So it conceptually, and I want us to be very clear.
yeah,
What we are saying is not that men who are having a good time are having depression. What we are saying is that because of the sex differences in the way men present with the affective disorders, that supposed good time may not necessarily be a good time. Because we have decided that a good time is drinking until you collapse and then say, I was high. But when you think about it, the people who are having that good time have a lot of emotional and disturbance. So, John, what I'm saying is, I'm not saying that everyone, even now in the evening, I'm going to go and have a good time. And don't assume because I'm having a good time, I'm depressed. But are we just masking? Okay? Are we just masking? Do men mask more than that? Because in these sex differences, you will find that's why it was very important that men will present more with irritability, aggressive behavior, and you'll say that, oh no, it's just that he's busy at work, but actually he's what? Struggling with an affective disorder, with mood, with sadness. Okay, and I think that's an important point because the way we to the outside world, the way we show off is really to mask sadness. Okay? And it's driven by the way the underlying biology, especially around the how male hormones prime us for resilience and stress response, both prenatally and at puberty. And then you add society, and then you add the way we are measuring it, and then you add the fact that we have means to do it. Then it makes you rethink how we should view these affective disorders like depression in men. I hope I've answered that.
yeah, no, you did. And I think you clearly mentioned the high risk moments. If a man is going through a high risk moment and you find him having quote unquote good time, then you should um, think about it a little deeper. Other questions are coming in. I share the first questions. Dr. Mwesiga, perhaps you could throw some light on the first questions I shared before Dr.
So
Jones,
I
then
think
I'll
the
give
one
the
for
answer.
psychosis is similar but not the same. And and
Mm.
and the neurodevelopmental model of psychosis is sort of different. You're born with a risk. You're primed due to certain risk factors around prenatally and early childhood, and that primes your brain to then when you get a second hit. Usually we talk a lot about the two-hit hypothesis. So you get the first hit, you have the genetic risk, you get an infection in intrauterine, then later you use cannabis, and then you what? You get psychosis. Here, it is more that your hormones prepare you to in a certain way. They are preparing you to be less expressive. They are preparing you to be more less risk averse. So you take more risks. They are preparing you to, not show fear, both prenatally and at puberty. Now, then when you get these struggles, right? So then you get depression. No, not depression, you lose a job. Then what happens, right? Before you know it, they say, no, he has lost a job, or his wife has died, but he's fine. He's outside hanging with friends. And then that becomes a societal norm, and then we are underdiagnosing and things like that. I hope that explains it.
Thank you. Thank you so much, Dr. Mwesiga. I'll request Nelson I'm going to send you a request to unmute, and you'll be able to then you will ask your question. Yeah. Oh, wait. Yes, Nelson, I think you're able to unmute, aren't you? Yeah. Go ahead. Nelson, you're unmute. Kindly ask your question. Okay, so we are not able to hear you. I'm going to request James Okello to ask.
Professor Okello.
Hello?
Yes, Prof.
Hello? Can you hear me?
Yes, Prof.
Yeah, thank you, Dr. Mwesiga. Thank you, moderator. Wonderful presentation. I'm very excited because now I can teach gender properly. Now, I wanted to ask a very direct question. The issue of male versus female presentation for depression. Given that there are differences which are very subtle but very important, do we still need DSM and ICD-10 for our settings, or what we need is just a higher index of suspicion and treating the depression? Thank you.
Thank you, Prof, for that excellent question. For me, so one of the things that psychiatry has not done well is tiers of care, primary, secondary, tertiary, quaternary. I think at a highly specialized level of care, you start with the diagnostic criteria, with the categorical criteria, right? You said depression, but then you start building layers. And I think that's where psychiatry struggles, because people at a specialized level, people think that all psychosis is haloperidol, or all depression is fluoxetine. But actually, the true issue is at a highly specialized level, you're now asking many other things. How much sleep? When do you sleep? What's the blood glucose? Da, 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 da. And that is more on a continuum, okay? And for me, I feel that we still need community health extension workers to say yes, no. That categorical distinction. It is when they and for a majority of people, like any other disease, that yes, no is good enough. We're all very proud of Professor Nachimuli's group psychotherapy. It's not, she's not going and saying that, oh, it is for severe depression with suicide. No, it is for mild to moderate depression. It includes an aspect of, employment and wealth and etc. So Professor Nachimuli doesn't need to be in the neurobiology and it. She just needs to have some way of separating people. then giving them a very good intervention and they will improve. And then those who don't improve then come up the lever to care. But what's happening now is that we are not differentiating the levers. So everyone is primary health care. Everyone gets fluoxetine or everyone gets psychotherapy, and we're not being able to do that distinction. And I think that's what I would say. I think they all need it, but we need to know where specialist care is and what it does, and we need to have specialist care. And that's why if there are any policymakers, that's why we need psychiatrists at regional referral hospitals. Because the community health extension workers can be trained to manage mild to moderate, can be trained to do psychotherapy. But then once you start this, depression and HIV, TB and psychosis, then you need it. Then it cannot just be yes, no, because it's no longer categorical. It's more complex than that. Thank you.
Yeah, thank you, Dr. Mwesiga. We have about 2 minutes to the top of the hour. I will request Dr. Nachimuli, the hand was up. Can you unmute and ask your question, please?
Mute. You can't allow.
We can hear you, Justin.
Oh, you can hear me now? Yes.
Yeah.
Dr. Mwesiga, thank you so much for the presentation. When you're discussing, I was trying to relate on how the men present, and they're quite similar to how adolescents present when they have depression. So my question is, could they be having an adolescent brain at that time? What is the biology about it?
I've opened the Pandora's box, I can see. So the adolescent brain, the adolescent brain is one of my favorite topics, and I did not
Can you help?
conceptualize it.
Just help me mute me. I'm
Okay.
done.
I did not conceptualize it like that, but I think some of so Justin, for me, what we are saying is you have only taken one aspect of the presentation, which is the biological, right? Now let's go to the norming, how we measure. Let's go to the societal expectations, and let's go to the access. Because the issue around depression in males, and maybe now we'll say older males, those are the key issues. That yes, okay, we may be presenting with an adolescent picture. So we are sleeping around and drinking, etc., etc. But we are masking. Yet an adolescent brain is just forming, what do they call it? They are pruning, they are forming networks, they're understanding themselves, understanding sexuality, etc., etc. So they are not, they may look similar, but they don't have the same role. For me, I would be doing it because I'm trying to avoid the fact that I have to go home and there's no food. Then the adolescent is just not going home because there's a good time. And I think that's the key distinction. Yeah. Thank you. Thank you for the nice question.
Yes, thank you. Thank you so much, Dr. Mwesiga. I think we have run out of time, but there are many questions in the chat. We are really sorry we've not been able to answer all the questions, but there was a question about what happens in high functioning depression. And I think the question of whether this applies to only affective disorders or not, I think it applies to other disorders as well. And but I think the specifics Dr. Mwesiga could highlight. Then I think I will also add a question that was asked by Dr. Mogumi about the tools what tools do we use for men? I don't know whether we have men specific tools or gender specific tools. Kindly highlight, and I mean,
So I was very cautious. I was very cautious about the tools because some of their psychometric properties are not yet that good. But that's not the take-home message. The take-home message is that as you measure, don't just get the PHQ, tick, 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 and say yes, no. Because a lot of the things in the PHQ are not always how the male depression presents. Okay? And and the recklessness. And you see now many times Jeremiah is talking about recklessness and things like
Yeah.
that, but it's in the context of masking emotional dysregulation.
And then the last question from Nelson, I think, is another interesting one, whether the use of exogenous androgens in certain patient groups like bodybuilders, women transitioning to be men, etc., whether this affects their brains as well and it alters their risk for affective disorders.
I don't think it only alters their risk for affective disorders, it alters their risk for many things. And that's why they have to be used cautiously so for example, in children transitioning, the rates of affective disorders are very high. Okay. But again, let me summarize. This time is up. Let me summarize with it. It is not just about the reason why we're talking about beyond testosterone. It is not just about the hormones. Many times we agree and we acknowledge that there are sex differences that are driving these small changes, but they also societal expectations, they also measurement challenges, there are health system challenges for men, and there are treatment challenges for men. And unless we have a discussion that encompasses all those, so it's not just about is he drinking too much or not, is he depressed? No, is he drinking too much? Is he able to acknowledge that fuel is now 7,000 and he can't drive a car and he has to take a border? Can he talk to a clinical psychologist before it becomes serious? Does he have a gun at home that he won't shoot himself? I think that's a good summary of what I'm trying to say. Thank you.
What a session. Thank you so much, Dr. Mwesiga. And I think we have tried to address all the questions. Again, these are sessions that are organized by the Uganda Association of Psychiatrists. This is our 6th CME this year. Look out for the next CME next month in July, usually on the last Friday of every month from usually 1 to 2. Today we changed to 2 to 3 because of some other factors, but we thank you so much for joining in.
Moses, we are going to remain at 2 because we moved to 2 because of the Muslim brothers and sisters.
Oh yes,
who have
yes,
Juma
yes.
at 1. So going forward, they'll be at 2 p.m.
2 to 3. Yes, thank you for that reminder. We're going to take a screenshot. Kindly, this time I think you're all able to switch on your videos. Kindly switch on your videos. You're going to take a screenshot in the next few seconds. And I'll be the one taking the screenshots. Kindly. Yes, I like the uniform here.
Hey, I didn't put on my camera yet, as in my good shirt.
No, your camera is on. Okay, so I'm going to take the first screenshot. Okay. Oh, sorry, I was speaking on the mute microphone. Thank you so much. I've taken the screenshots, 3 of them, and let's meet July, the last Friday of July, and have a good afternoon.